Hello friends, welcome to Cortex YouTube channel. In this video, I'm going to discuss a very important syndrome. Okay, let's begin with the case history here. A 12-year-old boy with fatigue, weakness, muscle cramps since few months, and there is a history of increased urination, and there is thirst, past history of recurrent kidney stones. Okay, on currently on potassium citrate. On examination, he is found to be hypertensive. Labs shows hypokalemia, metabolic alkalosis, and hyperrenism and increased aldosterone levels. Urinary examination or urinary biochemistry shows excessive chloride and increased potassium, magnesium, and calcium. That is hypercalciuria, hypermagnesiuria, and hyper potassium excreted in the urine. So on ultrasound, nephrocalcinosis is seen. So genetic testing was done for this guy, and the diagnosis of Bartter syndrome was made. Okay, they have given already diagnosis. So what is the most likely pathophysiology involved in this syndrome? So they have asked what is the pathophysiology. So Bartter syndrome, what happens? There is thick ascending limb of loop of Henle. In that there is your defect. So what are the defects? There will be sodium potassium 2 chloride channel defect. So sodium absorption doesn't happen, chloride absorption doesn't happen, potassium absorption doesn't happen, the channel is defective. So sodium, let's see the options here. Option A, sodium absorption in the thal is increased. No, it's not increased, so this is not a right option. Option B, decreased secretion of aldosterone in the adrenal cortex. This is also not wrong. This is also wrong. C, defective reabsorption of sodium and chloride in the thal. Okay, this looks fair enough. This is the answer. And decreased secretion of ADH from the pituitary. So this is also not correct. So option here is C. C is the right answer here. So let's look at the Bartter syndrome now. So what is Bartter syndrome? Bartter syndrome. See, it is one of those syndrome that affects renal tubules, channels of the renal tubules, where salt are absorbed. So there is absorption defect, reabsorption defect. So let's look at the pathophysiology. So this affects. Okay, let me draw a nephron here. This is your afferent, and this is your efferent. These are your capillaries. Okay, and this is your Bowman's capsule, and so this whole together forms glomerulus, and this is your proximal convoluted tubule. This is okay, this is loop of Henle, this is thick ascending loop, and here is your distal convoluted tubule, and this is your cortical collecting duct, and descends down to form medullary collecting duct. Okay, these are all your, this is your simplest form of nephron. Okay, so Bartter syndrome affects this part. Okay, this is defect in thick ascending loop of Henle, shortly called as TA, thick ascending loop, thick ascending limb of loop of Henle. Okay, oh, what is the defect? Let me draw a cell and show you. So this is your lumen of the tubule. So this is your cell, and this is your vessel side or blood side. So what happens here? See, filtrate is filtered out from the glomerulus. Glomerular filtrate, whatever comes here, it is rich in sodium, potassium, chloride, calcium, magnesium, all the ions, bicarb. So sodium, potassium, potassium, chloride, okay, calcium, magnesium. Okay, this is another cell. Okay, so how they are absorbed? They are absorbed by your special channels. So this is your one of those special channel which absorbs sodium, potassium, and 2 chloride molecules. So this is called as NKCC2 channel, sodium potassium 2 chloride channel. Okay, so this is that channel, and there is one more channel here which excrete potassium, or which secretes potassium to maintain the luminal positivity. So let's suppose all these ions are absorbed, so there is electron neutrality. So but the grading system is such that the lumen is always kept positive and the cell is kept inside the cell is always kept negative. So because this is very very important for absorption of calcium and magnesium. So if the lumen is kept positive, so calcium and cellular inside cellular is kept negative. Because of this negative inside, calcium and magnesium are drawn towards and they are absorbed. That is, the absorption of calcium and magnesium depends upon this gradient. If this gradient is not formed or this gradient is not maintained, so absorption of calcium and magnesium doesn't happen. That's what exactly what happens in ROM-K defects. So these potassium channels are called as ROM-K. What does ROM-K means? It is renal outer medullary potassium channels. So this calcium and magnesium have paracellular absorption. Okay. So along with sodium here, water is also absorbed. No need to mention because sodium is osmotic active compound. So it draws whatever wherever it goes. So here there is one more special on the basolateral membrane. There is one more specialized channel which needs a subunit Bartin for its activity. So it what it does is it excretes chloride to the blood. Okay. So and there is obviously on the basolateral membrane of cells, there is each cell will have sodium potassium ATPase. I am drawing this bold because this uses ATP for its activity. So it throws 3 sodium out and takes 2 potassium in. So this is very essential in maintaining resting membrane potential. And there is one more receptor here called as calcium sensing receptor. All these receptors and channels are very very important in maintaining the gradient. Okay. So any defect of this any channel mentioned over here will cause Bartter syndrome. Depending upon the channel involved, we classify it into different types. So what happens in Bartter syndrome? So let's suppose this channel is defective. Okay. Let's suppose this channel is defective. What is that channel? Sodium potassium 2 chloride channel is defective. What happens there is, so those sodium potassium and 2 chlorides are not absorbed, so they are excreted in urine. So whatever the filtrate sodium potassium chloride is there, they are excreted in the urine. So you get hyponatremia, hypokalemia and okay. And there is, since potassium is lost in the blood, potassium and hydrogen are very very close friends. So potassium goes out means H plus will also goes out. So there will be what is metabolic alkalosis. So body is losing acid means metabolic alkalosis will be happening. Alkalosis. So there is metabolic alkalosis, hypokalemia and metabolic alkalosis. So since the gradient is not maintained, calcium and magnesium will also go into the urine. So there will hypercalciuria. So hypercalciuria and hypermagnesiuria. So magnesium and calcium are lost in the urine. But you don't get it is not reflected in the blood. It is, so it doesn't cause hypocalcemia and hypomagnesemia in Bartter syndrome, because the magnesium that is not absorbed in the thick ascending limb is going to the distal convoluted tubule. There it gets absorbed because of the increased compensatory mechanism. So let me repeat once again. The magnesium that is not absorbed in the thick ascending limb is getting absorbed in the DCT. Okay. What happens? So I'll write here clinical features. First let me discuss the types. So if this channel is involved, this is called as type 1 Bartter syndrome. If ROM-K channels are involved, this is called a type 2. And if this channel is involved, chloride. What is this channel? This channel I forgot to mention here. It is chloride channel. Okay, ClCnKb. This channel is involved. It is type 3 Bartter. And this subunit Bartin, if this is involved, it is type 4 Bartin. And calcium channel, calcium sensing receptor is involved, it is type 5 Bartin. So let me write here once again. So type 1, what is involved? Type 1, what is involved? Sodium potassium 2 chloride channel is involved. Type 2, Rom-Kale channel is involved. And type 3, what is involved? Cl-CNKB channel is involved. Type 4, Barton subunit is involved. Type 5, what is involved? Calcium sensing receptor is involved. So all type 1 to type 4 are autosomal recessive, while type 5 is autosomal dominant. And type 4, special feature of type 4 is it involves sensory neural hearing loss. Patient also presents with sensory neural hearing loss, SNHL. Okay. And yeah, type 1 and 2, special features of type 1 and 2 have they presents with nephrocalcinosis, because there is hypercalciuria. Calcium is moving more or in the urine, so it is more in the tubules. So if calcium is more in the tubules, if the calcium is more in the tubule, it forms stones, so nephrocalcinosis. And yeah, type 1 and type 2 are majorly antenatal. They present in antenatal period or neonatal period. So type 3 has a childhood presentation. So these are all clinical important features about these types. Okay. These are regarding types. Okay. What are the clinical presentation? How does a patient presents to us? So clinical presentation includes, let me explain with the pathophysiology mechanism. So there is loss of sodium. Because of this, there is loss of there is a loss of water also in the urine. So you get polyuria. So polyuria, how it presents? Increased frequency of urination. Because of this, what happens? Patient is losing water. Because of this, there will be dehydration. When there is dehydration, there may be hypotension also. When there is dehydration, patient's thirst will increase and he starts drinking more water. That's polydipsia. Polyuria are the presenting symptoms. Next, the patient is also losing potassium. So how does it affect? It causes muscle cramps, fatigue. Okay. So, and since it is a child, there will be failure to thrive features also. And what else happens? So what does on examination there will be BP will be normal or reduced. As I already told here, you may find hypertension also in these patients. So on lab values, what all it tells? So lab will tell hyponatremia. I will write here. Yeah, that's better. Hyponatremia, hypokalemia, metabolic alkalosis, and what else it shows? Yeah, urine measurement shows hypercalciuria. So since in urine acid is lost, so you may get urinary pH, acidic urine, that is urinary osmolality will be increased, and hypercalciuria and hyper. Okay. So next, these are lab values, and I have so there is peculiar this hypokalemic metabolic alkalosis. I have discussed the approach to the metabolic alkalosis with hypokalemia in separate video, the link of which will be given in the description. Please watch that video also. And so this is the clinical presentation and lab values. Okay. Next, so how to treat these patients? Okay, how to treat these patients? So I didn't tell you one factor here. See, this the same channel whatever I told here, the sodium potassium 2 chloride, this is also blocked by your drugs known as loop diuretics. They are your furosemide blocks this drug and causes exactly same as this. Okay, same picture as Bartter syndrome. It's next. So how to treat this condition? Yeah, in pathophysiology, I missed one point. What happens? This unabsorbed sodium, potassium, and chloride, they go to DCT. DCT. So because of this, what happens? Excess unabsorbed sodium, potassium, chloride reaching the DCT, macula densa senses it, and what it does is, because it is unabsorbed, so body thinks it is not. Uh, so it is less filtered, so or there is dehydration, so body will start secreting, or your macula densa will start secreting renin. So there will be, that's why there will be increased renin ras activation, basically ras activation, increased renin, increased aldosterone. So you might ask, sir, there is increased aldosterone. It should cause absorption of sodium in water in the collecting duct. Why it's not happening? Why there is hyponatremia? So what is happening is, here aldosterone will be there. It start reabsorbing the sodium and water, but the absorption capacity from aldosterone is not sufficient enough to cause sodium levels to reach normal values, because there will be continuous loss of sodium, because this channel is only defective. So this loss will exceeds the reabsorption effect from the aldosterone. That's why there you get hyponatremia. So next, so how to treat this condition? So whenever there is increased renin, there will be local, so increased local prostaglandin E. Prostaglandin E will be elevated. This condition was earlier known as hyperprostaglandin E syndrome. So there will be increased PGE, and this has systemic effects also. So that's why giving NSAIDs in these patients will have improvement in this patient's general condition as well as kidney improvement. So how to treat these patients? See, one thing is they are losing excess salts in the urine. So sodium is lost, potassium is lost, calcium, magnesium is lost. So how to treat this patient? Salt supplementation. First thing is salt supplementation. Second thing is NSAIDs. Why NSAIDs work? They inhibit the formation of prostaglandins. So what drug can be used? In fact, even antenatal indomethacin also, some studies show improvement, and so indomethacin is given. Indomethacin and ibuprofen can be given. Indomethacin, what is the dose? 1 to 4 mg per kg per day in divided doses, 4 divided doses. So it is 1 to 4 mg per kg per day. You divide it into 4 doses and give to the patient. Or you can use ibuprofen also. Ibuprofen, what is the dose? 20 to 30 mg per kg per day, divided in 3 doses. Divided in 3 doses. Okay. Yeah. This is about Bartter syndrome. Hope you find this video informative. If so, please like, share, and subscribe. Thank you.